Hi there, I'm Dr. Paul Houle, and today we have another exciting episode of How I Do It. Today we're fortunate enough to have as our guest Dr. Miguel Loureiro from Porto, Portugal, and he's going to talk to us about endoscopy of the cervical spine. Welcome, Miguel.
Hello, Paul. Thank you very much for the invitation. It's an honor. It's a pleasure to be speaking with you this evening here in Portugal.
So,
I work in Porto. I work in public and private sector in several hospitals. Uh, I'm first Hospital Centro Hospitalar Universitário São João. It's a university hospital, and also at the Lusíadas private hospital. I'm an orthopedic surgeon, and I work mainly in spine.
so tell me, how did you get started with endoscopic spine surgery?
Uh, My interest in minimally invasive spine surgery started from the beginning. Actually, I did a visitorship in the United States at Twin Cities Spine Center with Jim Schwender, and my interest in tubular surgery, minimally invasive procedures started from long ago. Endoscopy. I did injections and stuff, and then I read this paper from Korean guys that they were proposing for us to do a transforaminal injection through the Cabin's technique. So I read the paper, start doing my injections through Cabin's technique, and my interest started there. So I combined my interest in tubular surgery, Cabin's approach to the foramen, and then I hooked up with Ralph Wagner. He came to help me with the first two surgeries, one interlaminar, one transforaminal, and then I took to it. I started doing it in 2018.
And I've been fortunate enough to visit you and watch you perform surgery, and I can attest to how skilled you are. And you're going to talk to us today about and give us some tips and tricks on cervical spine surgery, which is a more advanced technique. I'm looking forward to hearing your tips and tricks so that I can incorporate them in my practice.
So cervical endoscopy, it took a while for me. I had a fairly extensive experience in lumbar endoscopy. I even did some thoracic cases, but it took a while for me to start doing endoscopy. And why? I think it was a case that Ralph shared. I think it's on YouTube. He shared the case. His first cervical posterior foraminotomy. He started doing the decompression, and then he identified the structure. It was not the nerve root, it was the artery. So it was a vessel, a very big vessel that we want to avoid when doing cervical posterior surgery. So I was kind of scared of doing surgery because ACDF has such an excellent results. It's I think I look at the CDF as a minimally invasive procedure since you don't cut anything, and it took a while for me to start doing it. Um, and I only do posterior approaches. I don't do anterior approaches through the endoscope. Not yet. I saw your video, Paul. You were at Wordle with John Suk Bake, yeah?
Yes.
Yes. I saw it, and I saw some colleagues talking about it, but I kind of exited a little bit before going anterior with the scope. But posterior, I think it's an excellent indication because it's the same surgery that we do with the tubes, and as I think several advantages because it bleeds less. You can look around corners. The great advantage of the endoscope, you can rotate it and get the advantage of the angulation and look around corners and take less bone and do an extensive decompression. So the indications, the kind of patients that I operate on with the endoscope and the cervical spine, I for me are foraminal stenosis unilateral for now, foraminal disc herniations, central stenosis with associated or not foraminal stenosis, and mainly due to hypertrophic flavum ligament. For now, my contraindications, when the foraminal stenosis is due to vertical foraminal stenosis with the pedicle, upper pedicle and lower pedicle Very nearby, I don't do endoscopy. I have to do a reconstructive procedure and put in a cage.
So just to be
I've done
clear,
one case of,
you mean that in patients where there's significant disc space collapse and say foraminal stenosis from the associated osteophytes, you would consider that to be a relative contraindication?
yeah, for sure. I've considered doing it in elderly population, elderly patients, and perhaps I will do it. I have a patient that I'm kind of thinking of doing it, but for now it's a contraindication for me. I think it's better to go from the front and put in the cage,
Yeah, I happen to
or
agree with you on that one.
okay. Bilateral. I've seen several people doing it. Bilateral foraminal stenosis. I've done one case, and I don't think it's a good indication. I think it's easier to go from the front, and we have to be careful because as we all know, the medulla oblongata cannot be manipulated. So if the disc herniation is medial to the lateral border of the spinal cord, it's not a good idea to go from the back and try to get to the fragment because you can get into trouble. So disc herniation just in the foraminal space for me. I stole this these two slides from Christian Valencia from Chile regarding learning curve, and the right from Peter German. I saw on Seattle Science Foundation TV channel. I saw this video with Christoph Hofstetter regarding learning curve, and I stole this for them. For me, as I told you in the beginning, it took a while before considering doing a cervical endoscopy. But I've seen some colleagues with less experience in lumbar endoscopy that they started doing it earlier in the learning curve. I think the reason why is because there's lots of information around nowadays. We talk with each other. There's this community in endoscopy, and people learn to do it earlier in the learning curve. So perhaps not step 7 nowadays.
I think that's a great point because, back when we started, there wasn't a lot of training and it wasn't as popular. And now, as it's gained popularity, there are so many people doing surgery endoscopically that they're gaining more experience and the training's a little bit more accessible. So that's a great point that you're making because that's one of the things that people talk about is a learning curve. And I think that I don't think the learning curve is any different than with any other surgery, but our access to training now is significantly better.
Yeah, for sure. Access to training, and there's a lot of information available on the internet, on YouTube, on channels. We can learn a lot just listening to people that are more experienced than us. And for me, the guy that finally convinced me to start doing a posterior procedure was I think you know him also, was Vincent Hagel from Germany. We were in Lisbon in this endoscopy course, and we shared some insights. He shared a lot of insights with us regarding posterior endoscopy. And if I'm convinced that it's not, if we know the anatomy, we know how to control the endoscope, we know that we cannot let the endoscope fall on the dural, not on the dural sac, on the dural cord. So we know how to control the shrill. So then I think the main difficulty is choose the cases and do the so-called transition from palpation to the visualization. I think that's the critical step because if we can access the lateral mass, the so-called V point, in a safe manner, the surgery in itself we can do it because we recognize the anatomy. The scope that I use the Alicis Pro, the same scope that I use in the interlaminar, and I also use the CISIS, the dedicated scope to posterior endoscopy. So the interlaminar window in the cervical spine is smaller than in the lumbar spine. And when I did the first cases, I found that this transition from visualization on the X-ray to palpation, to the palpation, the feel that we feel with dilators, it's more difficult because we are not as used to it as in the lumbar spine. We feel and we know that it's more critical. It's cervical spine is not um, as lenient as the lumbar spine. So we hesitate a little bit more before feeling the bone. We have to feel bone. We have to find bone, and if the docking is good, if the docking is perfect, and if you can scrap bone and find the V point almost touching and looking at the X-ray, when we put in the scope, the endoscope, everything is easier. I'd like to show you this paper from Korea. What they did here, they studied the relation between the V point and the size of the dural cord, and what they found out that uh, was that in the lower levels, C5, C6, and C6, C7, and in the elderly, the dural cord is wider. So we should anticipate that we have to take more bone when we operate on these levels in elderly population, which happens a lot. So when we dock in the V point and start doing bony decompression, the first structure that we found, neural structure, lots of times is the dural cord and not the nerve roots.
Yeah, I think that's
There's
an
two ways.
important point. And really, again, recognizing the relationship between the bony anatomy and the neural anatomy is extremely important.
Yeah, for sure. This paper caught my attention because I experienced that. In some cases, you get to the V point to start doing the bony decompression, and then when you take out a little bit of the flavum, you see the nerve root, and then it's the method to widen the foraminal decompression to the upper pedicle and the lower pedicle, and it's kind of an easy procedure. Easy, not easy, but easier procedure. But lots of times when you start doing the bony decompression and open the flavum, the structures that appears, the first structures that appears is dural cord. So you have to go take a little bit more of bone and go lateral. There's two ways to do this approach. The first way described, I think it was described by Korean group and Sebastian Roten, is a direct approach in line with a disc. And I started doing this like this, direct approach, direct with the disc. There's another way to approach this, and described by Christoph Hofstetter in this atlas of full endoscopic spine surgery. You take an angle parallel to the disc, an angle line parallel to the facet joint, and you draw a line in the middle of these two lines, and this is your angle of approach. Even if you're not as precise as these lines and angles, the idea here is to get into the V point with a little bit of caudal rostral angulation. It facilitates to do the decompression of the IAP and the upper lamina. I find that sometimes it's more difficult to get to the lower pedicle. So I've done both. I kind of adjust my angle of approach to the cases. I don't know what you think about this.
Yeah, I think that I prefer the more angled approach, and I like to land on the facet joint of the superior lamina. For me, I just think it's safer. It gets me directly on bone, and you have enough manipulation of the scope to get to everything. But I think just the initial targeting, I prefer that better.
Okay. Positioning, I don't use any kind of traction. I don't think it's needed. It's just to get a good X-ray, to try to get the C-spine parallel to the floor. Um, but no traction, no maple. I don't use maple, just use maple when I have to put in screws in open procedures. I have this video. I think it's it's a funny, not that funny now. My cervical case, and I'll show why I'm telling you it's funny. 67 patient with foraminal stenosis. This is the advantage of the endoscope. You can turn the endoscope 180 degrees and look around corners and look outside to the foraminal zone. And when I opened it, I had this double root because you have the sensitive branch posterior and the motor branch anterior. And it was kind of a scare because I saw the root and then I saw this structure below the root, and I thought, oh, this is disc. But then I was not seeing everything clearly. I did not manipulate and anything. I just enlarged the foraminotomy, and I saw it was this double branched root. Um, and it happens up to 20%. It's a note of caution. You know, when you see the root, you don't think like in the lumbar spine that you can push the root upwards and take out the disc, because it's not disc. It can be. Have you found something like this in posterior procedures?
No, I've never seen anything like that, and this is a good point to give to people because you know only 20% of up to 20% of people that could really give you a lot of trouble,
Yeah,
and that's
yeah,
something you want to
yeah.
see. When you get in there and you're like, oh my god, where am I?
Yeah, it was a scare because I was thinking this is disc. I just show in the video the final image with everything is seen clearly. But as you know, in endoscopy, you take a little bit of more tissue and you see everything. But before taking it, not everything is as clear. So when I found the root, the upper branch of the root, below it really looked like disc. So if we are not careful and exposed from pedicle to pedicle, from the upper pedicle to the caudal pedicle, the foramen, we can get into trouble. So, and this is the final result on the skin. Again, same kind of case. C6, C7, this is an elderly patient, not that much of disc material, but for pure foraminal stenosis. I think this is a great indication to do some first cases, because we can go anterior and put in a cage and the patient will be fine. But with this procedure, we avoid the fusion. That's it. So one thing. We don't have to do fusion if you only have foraminal stenosis like this. So this is a step by step. I mark the midline, and then I mark this lateral line. That we can go in the mid pedicular line. Okay, I mark these two lines, and then I put in a needle. This case, I did parallel to the disc. I was doing it in this phase, and then I do my transition from visualization to palpation parallel to the disc. This is the image, the picture that we get when we put in the scope. If we do a good transition, this is appears not immediately. You have to clean a little bit with a radio frequency probe and with the micro punch, but it doesn't take that long. So this really facilitates the surgery. And if we sit this V point, you see the upper lamina, the IAP, and the SAP going to the lower lamina. Half of our work is done, because then our cannula docks in this point. I just cut in a cannula from another surgery and docked it here. And the bony decompression, you have to do less, very less than you have to do in the lumbar spine. Everything is smaller. You have to be more careful, of course, but everything is smaller, so it doesn't take that long.
So one of the comments that I've heard at some of the courses is that in the lumbar spine, when you do an interlaminar, there's a lot of muscle and soft tissue, and it's kind of a pain, pardon the pun, pain in the neck to do. Do you find the similar situation in the cervical spine? Is there a lot of muscle that you have to take away to expose the lamina?
Yeah, that happens when I cannot do this. In the first cases, I could not do this transition from visualization to palpation. I could not feel solid. Well, I could feel solid bony contact, but a little bit. When we do that and put in the scope, we have to deal with a lot of soft tissue and bleeding, and it takes longer. And another thing, it's useful to do to really with your scalpel really cut the fascia because the neck muscles, the muscles from the neck, are harder to overcome with the dilators than on the lumbar spine. So you have to cut the fascia really well. Some people control it in the extra and the lateral position, and then overcome this resistance from the muscle with the dilators. And if you can scrape the bone with the bevel dilators, you don't have to do that much of soft tissue resection. But if you cannot do it because you don't feel confident, you don't feel this that bony contact, you're not sure. Sure, for sure, you will be dealing with a lot of soft tissue.
So that brings up a really good point about the retractor and the bevel. Do you use the same type of beveled retractor that you do in the lumbar spine, or do you use one that's slightly less beveled in the cervical spine?
The cannula, yeah,
The
less
cannula.
bevel, yeah, the cannula. The dilators, I don't use the first one from the Elysis Pro because it's pointed, it's very aggressive. I don't use it. I'm afraid of using it, so I only use blunt dilators, and they kind of work like a cup. You've seen it, you use it. So they have this longer part. They are beveled also, the dilators, and I try to scrap the soft tissue from the bone, from the upper lamina, from the IAP, and from the lower lamina, from the a little bit of the SAP. If I can do that, if I can feel the anatomy as I do in the lumbar spine, I know that my surgery will be easier. If I cannot feel it or I'm not sure, it will be harder. So yeah, I think it's a key point.
This also begs the question. There's a lot of interest right now in the dual portal technique in the lumbar spine. Do you see any role for dual portal in the cervical spine?
I do. Uh, in our meeting from Portuguese Spine Surgery Society, a surgeon, a neurosurgeon from Mexico. I think you know him also, Javier Kilo Oliveira.
Mm-hmm.
Do you know Javier?
I know him very well. As a matter of fact, he's doing the next episode after you.
Okay, Javier made an excellent keynote regarding biportal, not only biportal, but cervical and the application of biportal on the cervical spine. And Javier is really an interesting guy to listen to because uh, he has done a lot of unipartal and continues doing unipartal, and it's a guy with a fresh perspective from a unipartal guy like me.
Mm-hmm.
What biportal can add to what we already do? So it's a very, I'll be looking at that episode for sure. I think there's a place biportal, more severe stenosis. If you start doing biportal for my what I can understand because I don't do it yet. Some cases that you anticipate that you'll need different angulation from the camera, it's perhaps easier. I don't know. He made an excellent keynote. I was listening and looking with attention, but I haven't done it. I think there's a place. So again, same thing, transition from palpation to visualization, and then again from visualization the right visualization in the endoscope. The kind of picture that we get, and then we do the bony decompression, like always. Upper lamina, IAP to expose the SAP. Uh, Contrary to the lumbar spine, the flavum kind of ends quickly. If we go lateral doing our bony decompression, lots of times the flavum just ends, and it's kind of a limit to stop using the shrill and start identifying everything. And you see that the nerve root appearing there. We just enlarge it. The goal of this kind of surgery is to do the compression from pedicle to pedicle. And you can see the pedicle. Rotating the endoscope, you can see the lower pedicle and the upper pedicle. And when we have to go and to the ventral space to resect tissue, osteophytes or disc herniation, we have to do a little bit more of resection. And regarding if it's on the cranial or caudal side, that depends where the disc is. So this is the final picture of a case that I had to go and grab a sequester. Fortunately, it was a sequester. I didn't have to do any kind of rotations. Just got there and grab it. And this is the final picture. I think it's a beautiful picture. We see everything, and we've
So one of
avoided
the
fusion
questions that
in
I
an elderly
frequently
patient.
get, one of the questions that I frequently get, and especially coming from the tubular realm, is oftentimes there's an awful lot of bleeding, and so the way we have mitigated that was to do the patient sitting, so the blood would just drain out. But do you find bleeding to be much of an issue with visualization with the endoscope?
Uh, it bleeds less than with the tubes. One of the reasons that I've done, I did some, not a lot, but I did some tubular foraminal decompression. But one of the reasons that I didn't like that much the procedure because it bled a lot. I was always using flow seal and compression and stuff. With the endoscope, it bleeds less because of the pressure of the irrigation. And also, again, if we can do this good transition to palpation from the beginning ad initium, it won't bleed that much. So I think it's one of the advantages. The other one is look around corners, rotating the endoscope. But if you can dock on bone from the beginning, it will bleed less than with the tubes, but a lot less. So this is a kind of an edge case. It's stretching a little bit the indication, but this is an elderly patient, 85-year-old, but with a lot of life in her. She had a prior CDF in another institution, but due to myelopathy, she was not satisfied with the surgery because, well, she didn't understand, or she didn't want to understand at the time, perhaps, that the surgery only promised to stop the evolution of the symptoms, and sometimes she did not get better with the surgery, but she didn't not get worse because it stopped the progression of the myelopathy. She appeared in my private clinic with um, symptoms, kind of a mixed symptoms with radiculopathy on the left from foraminal stenosis in this adjacent segment, C67. But she also told that she had worsening of the myelopathic symptoms. She was worsening of her capacity to deambulate, to walk. She was feeling worse. So some she was referred me to try to do some endoscopic procedure because she did not want any major surgery. She did not want surgery from the front. And well, I thought, okay, I can do foraminal. And in this kind of cases, it's not that difficult to go do the approach as ever. And then after doing the foraminal decompression, we can go to the midline and resect flavum ligament. So it's just a matter of angulating the scope. And here in the C spine, it's even nearer than in the low spine because you have to take less bone. So it's doable. The patient got much better from the radiculopathy. And regarding Nurik's scale from myelopathy, I think objectively she's the same, but subjectively she tells me that she's better. She's walking better. I don't know. Perhaps it's just a subjective thing, but I did this over the top decompression. I took the buckling flavum, and I think it's a good procedure, good indication also to do.
Oh, that's fantastic. I mean, if you think about
And
what you
this
were
is
able
my
to, oh my God, look
best.
at that picture. That's great. That was wonderful. For the viewers, we were in the Azores and we did endoscopic lumbar fusion. That was a great day.
Yeah, yeah, for sure. This is a fantastic picture, and to show that we learn with each other, and learned a lot from you when we were in the source, and when you were in Porto with me, helping me with the endolifts. Um, and I learned also, I think you know, the protocol to do an algo sedation, and to do this surgery in a wake fashion. And I had this. I know this how I do it. It's for cervical spine, but I have to share this with you. I had this patient when I was in the Eurospine that she had a foraminal stenosis, but foraminal stenosis with severe radicular pain, like hyperalgic sciatica for L5S1 foraminal stenosis. But she was also she had also metastatic breast cancer. And then the anesthesiologist told me on the phone. I was in Neurospine in Frankfurt. Told me, "Oh, Miguel, no, you cannot do surgery on this patient. This patient is for palliative care. There's no way we can go and do surgery on this patient." And I knew that palliative care and medication wouldn't work because I asked for a transfemoral injection in the radiology department, and the patient got better for about 1 day and a half or something, and she was crying all the time and going to the hospital. Uh, and I told my anesthesiologist that, oh, Manuela, this is palliative care. We have to operate this lady, otherwise she will die soon. So we can go and do an algo sedation. I have this excellent protocol that my friend Paul Houle, Dr. Paul Houle from the United States, shared with me, and we can do it. I shared the protocol with her, and then she told me no, but she cannot tolerate the prone position because she had to have thoracentesis due to her metastasis. So we go lateral. We'll do it. It's doable. Long story short, I did the trans SAP approach to do the foraminal decompression, and the patient was so grateful, Paul. It stayed with me until today. It, I think it's again another paradigm shift. We can do things that we could not do otherwise. So thank you for sharing.
Well, thank you for sharing that story because, let's go back. Let's go back to stop sharing your screen. I'm going to go back to the other where we're side by side. You know, thank you so much for sharing that story because one of the most important aspects about endoscopic spine surgery is we really don't know where this is all going to end up and what we can actually do. And one of the things that I like to, when I teach, is say, this is not a procedure, it's a platform. And we don't even know what we can do with this platform. And to be able to incorporate many different techniques to be able to treat that patient who otherwise would have just gone home and suffered. I mean, I think what we're able to provide our patients, what you were able to provide her, is just nothing short of remarkable. So
Yeah.
that's fantastic.
Oh, it was, and it was very dramatic because the patient, it was not the first time. It was the reawakening of this dreadful disease, and she was conscious of the severity of the problem. She did not want any further chemotherapy or something. Just want to live the time that she had left, but without pain, without suffering. So she was very grateful, and I was very glad I could do it because I had this nagging feeling that if I don't do this, nobody else will do it. So I have to try and do something, and fortunately, everything went well.
Oh, that's fantastic. All right, let's stop